no alcohol consumption history, no previous diagnosis providers, no pain increase after meals, so melina, no blood transfusion history, no needle injury, no unprotected states.
Married? Kids? So you know my humble. Always protected sex in your kids. Was the condom no unprotected sex. Children from other father. Oh, poor brand of condoms. What was the brand? We have to report it. Macha. चीरे में क्या में जाना है? वो करा. हाँ? apa? Ada lagi di sini? Patron apa lagi? Ada lagi tuh pilih ada dulu. Ikut kan? Sexual promiscuity. Kotu pernah kan? Ini kan kian non ya? Okay.
And after he had these symptoms,
ini cinta kan mana? Bagaimana dia makan? Kalau YouTube video करते हैं ना मैं इंडिया में कॉलेज सिंधु किया ना उधर सिंधु क्या किया कोई कॉलेज क्रिस्टल किया you also can sing you can't sing no so sing you can sing really well
he followed the Ayurvedic treatment, treated as hepatitis for 1 week duration, not because of not resolved. He had diploma student in investigation done and diagnosed as cholangiocarcinoma.
he told that he told that cholangiocarcinoma is there. Huh? Does he know? No, he doesn't know. That's what BHT is. Is it a BHT history? Huh? There's a BHT history. You think that's stupid? You got this here? It's a BHT history. What is a lifestyle? Huh? Good history.
Surgery.
He's awaiting surgery. Huh? Surgery? We are not going to do surgery because we ain't seen no problem. He doesn't need surgery. He has an assessment. For staging. Okay, which one question?
Previously well patient, suddenly developed previously well patient developed yellow discoloration of eyes and pale stools and dark urine before 2 months back, and it was progressively worsening over time.
Out of that 3 symptoms, what was the first symptom? Yellow discoloration of eyes क्या notice करना कौन है क्या है मुलीम मस्ता हो गया अंदर मारना मटा नूरे मस्त क्या का बर्बाद किया हाँ तो मुखा मुलीम नहीं लगती हम दटे ही ना टिकट क्या आप फिर याद है ना जी ऐसा कहाँ बच्चे क्या करते हैं जब मूर्छा आप दबा पा इनकी मेहनत है සාමාන්‍ය එරෝසිස් කරන්නේ කවුරුත් කිව්වම තමයි. මුලින්ම චූ කරන්න ගත්තාම මම මෙන්න තේ ගහට පාට චූ කරනවා. තේ බිබ් එකම යනවා වගේ. ඒක තමයි වෙන්නේ. මේ වගේ දතා නෝට් කරන්න. නැත්නම් loss of appetite ගොඩක් අර එක්ක නිකන් dyspeptic symptoms ඉනවා this loss of appetite loss of weight preceding. Then only they develop these features. I don't know what was the first symptom. I'm asking. Maybe make me ask urinal phase 2. Okay, go on.
It was progressively worsening over time, and he has had no abdominal pain. And due to these symptoms, he has seek medical advice, and initially treated as diabetes. And since there was no resolvement, he has gone for Ayurvedic treatment, which he has undergone for 1 week, and then got admitted to our hospital. With all the symptoms, he has had loss of appetite, loss of weight, nausea, and loss of body. And later he has developed.
How significant? Now, don't jump. Describe your loss of weight. How significant is it? What is the significant loss of weight? Is the loss of weight significant? How many kilos? Does he say that? Kilos की अखबार याद होना कि लगे ना? कौन लहानी को अंदाज़ है? अंदुम गुरु ने पालिसा में हालें लगा था. बेटे के विद्यार्थी लोग निकल दांड में तावा दिन हो. ये वाली. ना मुद्दा क्या क्या नगर ना? समाट विनय वाला मुद्दा क्या क्या नगर ना? मैं कहता हूँ ना मुद्दा क्या क्या ना? अंदाज़ मुद्दा तेरा मतलब बाबा गुरु दाग में करके बेलो क्या क्या करेंगे? तो मैं क्या करना है? So you have to explain how significant it is. वो समाप्त ले लोगे ना जब आता है इधर क्लिनिक के गैलरी में ना खाना पे गया तो बाहर पार्ट ना पे ने she's like twice the size of me. Man, I'm also fat and she's twice the size of me. And she says she's not neat. But then
And later he has developed right side abdominal pain. Right side abdominal pain, which was also inclusive onset and it was intermittent aching type pain with moderate severity. And he has had no sexual promiscuity. There is no history of IV drug abuse. No previous blood transfusions. There is no previous episodes of any gastric pain or burning sensation. There is no chronic back pain or no steatoria.
why did you ask that question? Why did she ask that question?
There is no hematomesis or hematomesis on pneumonia. He has no gum bleeding and he has no inverted sleep patterns.
Why did you ask about him? Periampere, see what you should ask. What is the specific question? Episodes of fluctuation of jaundice with associated with malaria.
No inverted sleep patterns. He has no history of any fever throughout this scenario. And he has no history of any and yes, no significant past medical history. And there's surgical history of right side lowering due to shotgun injury. He has no significant drug history, but he is allergic to cyanide. And he has no family history of any past in
Malignancy.
any abdominal malignancies. And he's on a normal diet, not on high cholesterol and vegetables with his occupation. And he's married and he has two children. He is 14 and 19 years old, was still schooling. His wife is unemployed, and he has been a chronic smoker with 9 factories.
How do you tackle factories? Divided months and how much? 20. 20. So if he smokes 10 cigarettes per day for 10 years, what is that number of factors? 10 cigarettes per day for 10 years. Hmm? 5 factors. That's it. Examination. Is there a difference in your history and her history? No? That's for lack of insight. It's patchy. Your history is patchy. Maybe you have. Mom, you could go to the cat. You could go to the cat. So we discuss. No more. That's why you are here. You have to present history in a chronological order. Try to be methodical. Use के नोट arrangement डाल दिया है. There, ये हो गया. And important things you can take from that. Right. लंकाव लोकसारा जुड़ा. Pida buat memang inon ya. You can tell that in Siddhastha and also in the first name. Okay. Similarly, important things can be taken to the front. From Pervert, I am sure it will be headlines in Sri Lanka news. Seriously, my people number will be headlines in US news. So important things now. Yes. Okay.
Examination, patient is connected and afebrile.
Check your now BMI. You have medical students active in all that. You can't sell an outcome at all. These are important cases. I won't be asking about dog bites, patients. What they can have, injection, you all need to know about rabies a little bit, that's true. But I will not be asking a detailed history. But these are long cases. And make a model history. This is all what you need to go through for the exam. Keep it aside. This is all what you need to go through for the exam. If you have a model history, 11 model histories, that's it. Catectic or not? Catectic is your observation. So you even be catectic. And maybe not be super obese. Yeah, you measure medium. Is there a scale in the wall? Is there a little height in the wall? Yes, check the BMI. At the exam also, if you are not given the chance to measure it, say the consultant, I would like to measure the BMI. He looks catectic, but I would like to measure the BMI. Say that. What cervical leaflet that she is worried about? Which cervical leaflet? Which cervical leaflet? Which side? Versus for the body versus for which side? Left? Neurodiagnostic? Left supraclavicular. What do you call that sign? Spellings? PRO. That diabetes causes so artery spasms. That is also wrong. PRO, PROI, SIERS, OECS.
On information of the abdomen is not distended and there are no surgical scars. On palpation and on superficial palpation, there were no tender areas, but on deep palpation, the liver was palpable, which is just 3 fingerlets below the right costal margin. And there are also MBBS.
Hard liver, nodular liver, firm liver, soft liver. Smoothing consistency. Smooth is the consistent, soft, firm, hard. Soft liver. Soft liver hepatitis or even tender.
Regular margins. There are also
Why do you think patient has liver hyperemegaly? Not because of the congestion. Biliary congestion. Why I am asking about nodularity. If there are nodules, you will think of nodules. Metastatic leukocytes. Characteristically, they have nodules in central umbilication. Pathology.
there is no splenomegaly and there was no free fluid in the abdomen and bowel sound.
What was the important negative or positive there in the abdomen other than the liver? I want to hear something else. Was it palpable? No. Okay.
And there was no free fluid in the abdomen and bowel sound.
Summary. Treatment or not treatment? Not treatment. Can you summarize? Summary is your interpretation. Right? So you can use medical. How old is the patient? 41-year-old patient presented with painless progressive obstructive jaundice. Without telling all 4 cardinal features of obstructive jaundice, summary is your interpretation. You don't have to use in patient's terms only. You can say 41-year-old male patient presented with painless progressive obstructive jaundice. That sentence has everything. Okay? Associated with significant loss of weight and loss of Okay. 41-year-old male patient presented with painless progressive obstructive jaundice associated with significant loss of weight and loss of appetite. What else? Any positives in the history? Any positives in the history other than that? Nothing, right? With no obvious risk factors. You can say that. With no obvious risk factors. Does he have any comorbidities? No. How can you add that? A 41-year-old ASA1 male patient. What is ASA? What is ASA grading? Have you done anesthesia? With whom you are doing? Dr. Nilangi Namahe again? Huh? Japur. Dr. Radhika. How did you consultant for you? The pretty one is not there. There's a pretty one. She's still there. So what is ASA grade? What does it ASA stand for? American Society of Anesthesiologists. How many grades are there? ASA 6. ASA 1, no comorbidities. 2, they have comorbidities but it's well under control. 3, they have comorbidities but they are moderately incapacitated. Moderate. 4, they have comorbidities and they are severely incapacitated. 5, they are moribund. They say 5 weeks, whether you do the surgery or not do the surgery, they are going to die. So you tell the relatives, look here, you are taking a chance. There is only less than maybe 5% of chance your patient is surviving, but we will still do the surgery if they are willing. If they are moribund. That's 5. What is 6 then? Huh? Yeah, brain dead. Brain dead. Why do you categorize an anesthesiology? Yeah, organ harvesting. Brain dead period for organ harvesting is ASA 6. So generally we take it 5. 6 is a special category for organ harvesting, brain dead patients. So you can say it's a 41-year-old ASA1 male patient presented with painless progressive obstructive jaundice for 1 month duration, associated with significant loss of weight and loss of appetite with no significant risk factors in the history. On examination, patient is deeply icteric, cachectic with a BMI of blah blah blah. No cervical lymphadenopathy. On abdominal examination, there was a firm hepatomegaly with no palpable gallbladder. Full stop. That is your summary. Okay? For God's sake, write a summary. Learn how to write a summary. Okay? Right. You have to take another history and present it. Patient. Maybe you can take mirror signal system, properly write it, and chronological order and present it. Okay. How will you investigate this patient? Okay. Before that, we discuss about history. It's a very simple history. So divide your history to several parts. You can't by heart histories, no. So there are 5 subjects. ඔයා මේකම කටපාඩම් කරලා මම මේ වහනවා කියලා දාන්න. ඊට පස්සේ දෙදාගේ කුමාරව තමයි අහන්නේ. OJ Painless. You should have your own abbreviations also. Now you will be given only 20 minutes for the history and examination both. Only 20 minutes at the exam. But once you come out of the panel with the patient, you will be given minimum of 20 minutes to get ready with your summary and everything. Everyone gets that. 20 or more. So you can even rewrite the history again. You have enough time. But you can't go back to the patient because there's another candidate with the patient. So you have to take everything and come out. You can't be writing complete sentences in front of the patient. You have to jot down important things like positives, negatives, and then write a history properly. So you should have your abbreviations. OJ, P. Among abbreviations, fever. What the F is කියලා තමයි බලන්නේ. තමන්ට මතක නැත්තම් මොකටද F දැම්මේ කියලා ඉතින් එළියට වෙලේ මොකක්ද F කියලා හිතන්නේ ඈ? So fever F, I have my own abbreviations. Right. So in the history, first is obviously 4 cardinal features of obstructive jaundice. First is age, where is he from, what is his occupation, just to build up a rapport, those things. And then what was the presenting complaint, and then presenting complaint may be just one, either pruritus or dark urine, pale stools, whatever. Then you ask the rest of the 4 cardinal features. Then whether it's progressive or not. Progressive or not. Or were there any fluctuations. That next part is then associated Loss of appetite, loss of weight. If there is loss of weight, how significant was it? You can also ask, may දෙකෙන් මොකද්ද මුලින්ම ආවේ කියලා. Whether jaundice the මුලින් ආවේ, loss of appetite, loss of weight. The relevance is, this is highly theoretical, may not be there always. It's highly theoretical. Now, if it's a malignancy, cholangiosis is a malignancy that occurs within the duct. Okay? This patient will develop obstructive jaundice first and then develop loss of appetite, loss of weight. Whereas a pancreatic HCA in the background of chronic pancreatitis will develop loss of appetite and loss of weight first, obstructive jaundice later. Highly theoretical, may not be there always. You can get the other way also. But in your history you can ask which came first. Okay? So then that part. The basic elaboration of your presenting complaint. Then you have to organize your history. විදියක් හදාගන්න හිස්ටරි අහන්න. නැත්තම් වෙන්නේ ලෙඩාගාවට කියලා වාඩි වෙලා ඊළඟ ප්‍රශ්නේ මතක් කරනවා. ඒකනේ වෙන්නේ දැන්. ලෙඩාගාවට කියලා වාඩි වෙනවා. ඔයාගේ නම මොකක්ද? ශ්‍රීපාලනේ. වයස? That is because you are not used to take history. They all have gone through it. විදිහක් තමයි අපි ඒක අමතක කරන්න, we repeat the patient's answer. නම සිරිපාල. 41. You don't have to repeat it. Why do we repeat it? Because we need time to think about the second question or third question. That is the reason. Right? So if you have your method of taking the history, it will not happen, or it will not happen to that extent. Now this is a patient with obstructive jaundice. Next is you differentiate whether it's a painless or painful. Painless or painful. All malignant patient, most of the malignant patient has a vague pain, moderate to severe pain, mild to moderate pain, severe, not maybe severe. It is not a biliary colic type pain. So they may have RH, upper abdominal discomfort, upper abdominal pain, everything. It is possible. Don't think pain malignant. If there is a nerve infiltration, obviously there is pain. If a pancreatic CA occur in the background of chronic pancreatitis, obviously they have pain. So that pain is different than pain. What else? Fever. Or else you can, after this, you think about the complications of obstructive jaundice. That is the next category. Then you think about the risk factors for malignancies. Then you think about metastatic features or the spread of the disease. Likewise, you need to have your category. Maybe you can get differentials. So those are the categories. You can mix it up, no problem. First you ask jaundice, 4 cardinal features, whether it's progressive or not, associated loss of weight, loss of appetite, painful or painless. Then the 4 categories are obstructive jaundice, well, complications, risk factors, malignancies, spread. You can ask questions to exclude or conclude your differentials. Those are the questions. Complications. So she asked, cholangitis. You can ask about fever, which is and ricos. Bleeding manifestations. Think about coagulopathy. Alter sleep pattern. Thinking about hepatic impairment. And reduce urine output. Think about hepatorenal. So those are the 4 main complications that occur in a progressive obstructive jaundice patient. So you ask in the history. 4. Then, if you are thinking in terms of malignancy, biliary malignancy, what are the risk factors? What are the risk factors? Huh? Okay, before we risk factors, we think about the DDs now. Okay, what are the differentials now? Ishan, I'll ask a question now. In this patient, up to this point, or in your history, what are the things in favor of a malignant condition? Or why are you thinking of malignancy? Why?
Because obstructive jaundice is associated with the
You start your answer by saying, although this is a middle-aged patient, that will tell the examiner you are considering the age also as a factor. If the patient is 65, you will think of malignancies than a 28-year-old. But this patient middle-aged. Although this patient is middle-aged patient, that indicates, okay, this girl is concerned about the age. Okay. So for middle-aged patient has painless, progressive. Two things, painless, progressive. Both are in favor of malignancy. Painless, progressive, obstructive. Anything else? Associated significant constitutional symptoms. 3. 4. Does he have fever in the history? No. I told you on that day, malignancies, generally they don't present with fever. The rare years, they develop fever after we interview. Whereas stone disease may or may not have fever. If they have fever, you think of stone disease first. So the fact that patient has no cholangitis is also more in favor of malignant condition. Okay. Anything else in your history? If there was a significant risk factors in your history, you can also tell the fact that this patient has a significant risk factor like chronic alcoholic or heavy smoker is also a risk factor given, right? So likewise, that can be a possible first question to ask in your case discussion. Okay, what do you think? Why do you think this? What do you think about this patient? Is this patient malignant condition or benign? Then you will say malignant. Why do you say it's malignant? So you have to start answering from the age downwards. Okay. Right. So we go back to this. Then obstructive jaundice complication. You think about differentials. Tell me your differentials. What are your differentials? Okay. Pancreatic CA. Perianthal CA. Cholangiocarcinoma could be distal or hilar. Why jaundice? Possible. Okay, internal obstruction. Anything else? Better than that. Hemolytic conditions. Can it be external compression by pericarditis lymph nodes? Secondary deposits in the porta hepatis from another primary. Gastric CA with secondary deposits in the porta hepatis. So colorectal CA with secondary lymph nodes. Very unlikely, but we have seen patients. Gastric CA is common. Gastric CA with porta hepatis secondaries. So external compression. So those are the differentials. So then you ask certain questions to exclude your differentials. Cholangio, there is hardly any question to ask because they have obstructive jaundice, loss of weight, loss of appetite. Those are the features. There is no specific feature to ask. Pancreatic HCA usually occurs in background chronic pancreatitis. So as you asked, you can exclude past history of non-patient with chronic pancreatitis. This patient does not give a history of chronic abdominal pain associated with loss of weight or steatorrhea, suggestive of chronic pancreatitis. Or there is no recent onset diabetes. So chronic pancreatitis can have exocrine or endocrine failure. So this patient has no past history of chronic abdominal pain associated with steatorrhea or loss of appetite, loss of weight, or recent onset diabetes, suggestive of chronic pancreatitis. That is another thing to do. You can ask. You can have chronic backache. That is also possible. Periampelmy, that we have already discussed. there is no history of fluctuation of level of jaundice or the severity of jaundice with intermittent melena. What is the reason? Now we have block tumor එකක් තියෙනවා periampulary region එකේ. Periampulary by definition, any malignancy that occurs within 2 cm radius of the ampulla of water. Ampulla of water के 2 cm radius से कहते हैं ना ओनम malignancy. So it could be duodenal, it could be ampullary, it could be cholangio, it could be pancreatic. That is by definition. But generally we consider, by in talking terms, we consider malignancy around at the ampulla. If we see a growth at the ampulla, we consider it a periampullary. But by definition, it could be any of the histology. Ampulla water will 2 cm radius से कहते हैं ओनम tissue एक में होगा. It could be bile duct, it could be pancreatic duct, it could be duodenum, anything. Right? So in the periampullary growth, if there is a growth which causes obstructive jaundice, the intrabiliary pressure goes up because it is obstructed. But this growth, usually malignancies are very friable, soft and friable. When the pressure builds up, tumor it breaks. When the tumor breaks, it bleeds. So patient will get his episode of melena, and what happens to jaundice level? It reduces. Then the tumor will regrow again and block. Jaundice, so this is a classical history, but I am yet to see a patient like this. But this is a textbook history. So you can ask. Intermittent episodes of melena and fluctuating the level of jaundice, severity of jaundice. So that is to exclude your. And also if you are thinking in terms of a benign biliary stricture, you can also add to here to differential diagnosis. If you are thinking of benign biliary strictures, you can ask this patient has no past history of any biliary intervention or upper abdominal surgeries. Add to that. You all understand what I am saying? මට බයයි වල දිහා බලන්න කියනවා. බයයි හිතනවා මට. කරදෝළු අත ගහගෙන ඉන්නවා. Yeah, okay now.
Oh, yeah.
You need your books? Oh, no, almost the brain. Very good. These are, if you are like journalists, you are the only non-journalist fellow here. I like it. Right. So then you can add that part also. So we have done this, and you are thinking of malignancies, you can think about the spread. Spread, local spread, loco-regional spread, and metastatic spread, distal spread. So we've spoken about the local regional and everything here. We'll think about the distal spread. What are the distal spread common ones? LLBB, liver, lung, bone, brain. Right? Liver metastasis, how do you ask in history? Loss of appetite, jaundice. Is there a point of asking it again? Because it is anyway there. So you don't know whether it's liver metastasis or not. Don't ask again. There is a patient coming with jaundice and loss of appetite. You ask that person that again to exclude metastasis. How stupid is that? Right? So you have already asked that question. Lungs, maybe hemoptysis or recurrent respiratory tract infection. Yeah. Bone, how do you ask the bone pain? Okay, nocturnal pain, severe pain which disturbs sleep, localized, severe nocturnal bony pain which disturbs sleep, typical. කොන්ද කැක්කමයි කියලා නෑ බා. 95%ම කොන්ද කැක්කම තියෙනවා. There's no gender bias in that statement. All genders, but generally more in females. Okay, bone, brain, early morning awakening headache or late onset seizures. But again, you can skip that. Do you think you will be given a patient with brain meds for the exam? Patient is like either dying patient or confused, disoriented like you all. may not be very not very fit to give history. But you can ask for the final year, for the completeness sake, you can ask. So that is the metastatic spread. Risk factors, what are the risk factors for these malignancies? One is we have already asked, that is chronic pancreatitis. Diabetes, if you have not mentioned anywhere, diabetes is a risk factor. Any other risk factor? What are the risk factors for cholangiocarcinoma? What are the risk factors for cholangiocarcinoma? Cholangitis. Sclerosing cholangitis. Who gets sclerosing cholangitis?
Females.
Females. Any other patient? Patients with I, B, D. Inflammatory bowel disease. That's extraintestinal manifestation of cholangitis. Lecture was done by Dr. Isha Premathilakar. I think I should write to her again. Go and see the note. If you know your pathology, you know 30% prefer surgery. If you know your pharmacology, you know more than 30% of your medicine. If you know your combat, I don't know. Oh, without me, that time. So, what are the other risk factors? So, how do you ask IBD in the history? Yeah. Whether this, we can say this patient does not give a history of altered bowel habits with blood and mucus, episodic blood and mucus diarrhea. Classically, it's young patient with episodic symptoms, whereas colorectal CA is not a young can occur in young people, but not an episodic symptom. IBD is episodic. On the venom or relapse. So you can say, you can touch all these things in your history. That is for that. Any other risk factor for cholangiocarcinoma? Diabetes is a risk factor. Hepatitis C is a risk factor. Blood transfusion, unprotected sex. Any other risk factor? Parasitology?
Fluke.
Yeah. What flukes? Which liver fluke? Huh? Chinese liver fluke. What is the name of Chinese liver fluke? Okay, I'm going to call Dr. Hasini Bandhakana. Clonakis sinensis. Now don't, in the history again, this patient has no parasites traveling to China, or Taiwan, or Korea. This patient has no history of Clonakis sinensis. I mean, don't say that, okay? This is only for theory purpose. If somebody, some dumbass asks, what are the risk factors? You know. Or if for MCQ, you should know. But don't say that in the history. Your long case, don't say this patient does not give history of Clonakis sinensis infection. For God's sake, don't say it. I will fail. That says you are a very bookworm type method. Follow pile anything. But it's only for theory, only for MCQs. How many cases you have seen? None. There's one of my group mates. He always says the rarest answer first. When you do pediatric, we've asked what are the causes for PUO, pyrexia of unknown origin. He has a very deep voice. He said, brucellosis. And consultant was very sarcastic. He asked, how many cases you have seen? He said, none, sir. Like that. You know. I haven't seen. Have you all seen Clonakis sinensis? Do you remember the shape of it?
Yes.
Huh? Fasciola hepatica. Fasciola hepatica. Acma patella. You all have not learned parasitology.
Not in parasitology.
මේව මොන මොඩියුල් එකද දෙන්නේ? Flukes are done in what? Ominobensin? Not that. Apa? එතනල මේ කක්කාගේ විතර පැන්ති මුන්නේ දාලා. නෑ නේ. අපරාධ ලකුණු 100ක් හම්බුනා විතර 4ක් ආවා. I got 100 marks. Find me 4 eggs. බලන්න නෑ නේ. Very smelly. කාගේ කක්කක් දන්නේ නැහැ. ඒලාට demonstrate කෙනෙක් කියලා tooth pick එකකින් හරියට හරි precious දෙයක් වගේ බිඳුවයි දෙන්නේ. බිඳුව slide එකට දානවා. ඕන තරම් තියෙන විතර. බලන්න නෑ නේ. You have missed your undergraduate period. You have not done anything. Finding eggs in a stool sample is amazing. Right. So it's a risk factor, but only for books. Okay. So now, can you, if you have this structure in your mind, is it easy to ask the history or not? So elaborate your preceding complaint. Think about the complication of obstructive jaundice. Think about your DDs and exclude. Okay, if you think it's a malignancy, ask about the risk factors and the spread. That's it. And to complete in your history, what are the investigations done so far in patients' work? මොනවාට වෙනකම් කරේ? CT scan එකක් කරාද? බඩේ scan එකක් කරාද? How do you ask this in simple terms? බඩේ scan එකක් කරලා කියලා අහන්නේ කොහොමද? ආච්චි කෙනෙක් ඉන්නවා අවුරුදු 70ක. Sopinona. She has come from Dambana. So how do you ask Sopinona from Dambana whether the ultrasound is done or not? බඩේ ජෙලි ගාලා ටීවී කරලා බැලුවද? That's a simple term. හොඳ නිකන් පොස්ට් ඩාල් එකකින් අහන්න එපා එහෙම. ස්කෑන් එකක් කරලා කියලා. No, you customize your question. හරි. patient එක රැවටෙන්නත් එපා. සමහර පොස්ට් වගේ ඩයල් ඉන්නවා. ඒලෝ ලම්පක් ගන්න. එතකොට CT scan අහන්නේ කොහොමද? ඈ? රෝගුණේ රවුමක් වගේ එකක් ඇතුළට ඇවලා ස්කෑන් එකක් කරාද? MRI? ලොකු රවුමක් ඇතුළට ඇවලා ගොඩාක් සද්දයක් කෙන එක ස්කෑන් එක කරනවා ලොකු සද්දයක් ආවා. ලොකු සද්දයක් එනවා. ඒක තමයි අහන්නේ. ERCP cutting camera එකක් දාලා පරීක්ෂණ කරාද? එච්චර you don't know whether it's upper GI or ERCP. නැත්නම් ඒ පරීක්ෂණය කරාට පස්සේ වගේ ඇස්වල කහගතිය අඩු වුණාද? So that means stenting done. So in patients done, what has been done so far. And you can also add some icing onto the cake and ask patient's wishes. Okay, now this patient is awaiting surgery and she is willing to undergo surgery. You are giving the patient's perception also at the end of your history of the presenting complaint. So your history of the presenting complaint should start from the day that you have a symptom and ends on the day that you are taking the history. Should be in a chronological order. Okay. Now this patient is awaiting this, and he or she is willing to undergo. He or she is depressed about the condition. He feels bad about the condition. Right. You can start from the most recent episode and tell that this patient's past history of similar episode or whatever. You can correlate like that. ඒක ප්‍රශ්නේ නෑ but ඔයාලා හිතනවා ලස්සන කතාවක් දාගන්න පුළුවන් කියලා එතනින් පටන් ගන්න. මොකද එක්සෑම් එකක් දෙන්නේ අපි කතාව එක්ක පිළිඩක් හදලා කියලා දීලා හරි මොකක් හරි හොඳට කරලා දෙන්නේ. එක්සෑම් එකක් දෙන්නේ නෑ යන්නේ කොහොමද මල්ලේ patients ලා. හරි එක්සෑම් එක දෙන්නේ හොඳට කතා කරනවා. එහෙම දෙයක් තමයි. If your patient is not cooperating at the exam, you can tell one of the examiner, whoever, you will be given a new patient with new allocated time. Because there are spare cases all the time. If your patient is not cooperating, just because you don't know the case, you can't say, sir, I am cooperative. Because let's say you have not studied breast carcinoma and you get a breast carcinoma. then you can't say patient is not cooperative because we know whether the patient is cooperative or not. Some patient are cooperative නැහැ. එක දාගෝ කතරගම දෙවියෝ ඉල්ල කතා කරත් මම නම් මෙතනින් හරිය වචනයක්වත් කියන්නේ නැහැ ඒවා. It's highly uncooperative. මෙතනින් හරිය දෙන්න බෑ. You have to remove that patient. So don't worry. If your patient is not cooperative at this time, tell us. We will give a new patient with new stuff time. New 20 minutes. Okay? Right. Systemic inquiry. මේමයි relevant ඒවා වුම දැන් ඉතින් මේල දාගෙන ආපහු අහන්න ඕනේ නැහැ මම දන්නේ මොනවද අහන්නේ මේල දාන්න. බව හැබිට්ස් ඇහුවා. urine output එක ගැන ඇහුවා. තාම මොනවද අහන්නේ? dysphagia. why chest pain? past medical history එකේ අහනවාට පපු යනවාරු ඇදුම හතිය ඒවත් ඇහුවා. මම දන්නේ I don't know. No, එහෙම විශේෂයෙන් අහන්න ඕනේ. I told you you don't have to subdivide, you know. ඔහොම ගොඩක්ම subdivide කරන්න ඕනේ නැහැ. Subdivide කරන්න. ඒ divisions තියෙන්නේ to have a chronological order only. But I told you if you think is a relevant significant history like now if this patient has diabetes, it's a significant problem. You can say 41-year-old diabetic patient presented with this. If you think it's significant. Or if diagnosed patient with chronic pancreatitis present with progressive obstructive jaundice. If it is in the diagnosis already, patient knows, you don't have to wait till past medical history to present it. No. No need. If you have already told patient is a diabetic patient, but if you have not elaborated how the severity of diabetes, what are the treatments that patient is on, then you can say. So you can customize your case. Okay. Right. Anything in the history? Any questions? Any questions? No. Examination. I'm not going to discuss everything about palpable gallbladder. It's important. If you get an obstructive jaundice patient, you have to tell about the gallbladder, whether it's positive or negative. Why? Ishani.
Because changes the diagnosis.
How? If the gallbladder is palpable,
It mostly relate with the smelling the disease.
okay. Whose law is this? Is the problem? I thought you don't know about who's this law. හොඳ දේවල් අන්තිමටම තමයි ඔය විභාගෙදී එහෙම ගන්න. හොඳ දේවල් මුලින්ම කියන්නේ හොඳයි තමයි. If you given easy to interpret, if there's a part test derivation ගත්ත ගමන් this patient has a heart rate of කියන කටු ගණන් කරනවා. And P wave is this, PR interval is this. අය හොඳයි this derivation එක famous. This patient has estimated MI in inferior leads lead 2, 3 and ABF. Tell that and then you this is the P wave, this is the QRS, this is the ST segment, everything like that. You have given the obvious diagnosis first. Then sometimes you can go for the discussion without wasting time on PR interval and this thing. Okay? So according to Courvoisier's law, for the question that I asked, the answer should be, according to Courvoisier's law, if the gallbladder is palpable in an obstructive jaundice patient, it is unlikely to be due to a stone disease. නැත්තම් ගෙදරකින් අම්මට තමයි Courvoisier's law එක කියන්නේ. බෙල් එක ගැහුවා. අපරාධ දැනන් හිටියා කියලා ගන්න වෙලා බෙල් එක ගැහුවාට. So answer. I really thought you don't know what Courvoisier's law. So everyone knows Courvoisier's law? If the gallbladder is palpable in an obstructive jaundice patient, it is unlikely to be due to stone disease. Why? If there are stones, there will be chronic polycystitis and the gallbladder will be contracted, not distended. Right? If the gallbladder is distended, obstruction has to be where? Below the level of insertion of cystic tube. You all agree? Yeah, it has to be something below. So what are the differentials? So if you are saying it's unlikely to be due to gallstones, what are the differentials? What are the differentials? Can it be a distal cholangiocarcinoma? Yes. Can it be a pancreatic head carcinoma? Can be a periampheral carcinoma? Yes. Can it be a distal stricture? Yes. Can it be a hyalopharyngeocarcinoma? No. Okay. If the malignancy is here. What is the other name for hyalopharyngeocarcinoma? Flat skin tube. Flat skin tube. Don't think it's a common condition, it's a rare condition. You will see a lot of cases because it's a referral center. Okay? Don't think it's a common case. You will see a lot of flat skin within next 2 months. It's not a common cancer. Even a gallbladder disease is not a common cancer. You will see a lot of cancers because it's a referral center. Right. So these are the differentials for this. What are the exceptions for this law? Courvoisier's law? Two stones. Double impaction. One stone here causing obstructive jaundice, another stone here causing mucocele of the gallbladder. It fulfills both the criteria. Gallbladder is distended, obstructive jaundice, and it is due to a stone. So that is an exception. Any other exceptions? How will you do? Spellings? I will write. MRI double is a die. Who is Mirisi? Surgeon. Argentinian surgeon. Good. The Argentinian surgeon Pablo Luis Mirisi. So he's called Mirisi syndrome. What is Mirisi syndrome? Samujata? Gallbladder, fundus of the gallbladder? Yeah, in the Hartmann's pouch. If there's a stone in the Hartmann's pouch, it can erode and block the common bile. There are actually several grades. You all don't need to do that much. There's a Hartmann's pouch like this. If there's a stone in the Hartmann's pouch, Mirisi type 1, because of the peristone inflammation, it blocks the CB. Because of the inflammation. So because of this inflammation blocking, if there is obstructive jaundice, because of this stone, patient has distended gallbladder. Right? So that's one. Sometimes there is a cholecystobiliary fistula. Stone causing cholecystobiliary fistula. So stone blocking this side and this side both. So there are like several grades. You don't need to know that much as postgraduate. So that is Mirisi types, right? So that is also due to stone disease, but that's also an exception for Courvoisier's law. So these are the two conditions which are exceptions for this. Okay, that's why you need to comment about the palpable gallbladder. If it is palpable, you have to say. If it is not palpable, you have to say it's not palpable. So in your patient, what is it more likely to be due to now? Block? Where? Above. High obstruction. Any questions up to now? No. Very sharp. Ekat exception No, very empty and only silent lamella. You have a question? CBD in situ stone. So how can just a CBD stone cause distended gallbladder? It doesn't happen. It doesn't happen. Just a CBD stone cause obstructive jaundice. For CBD stones, you mean primary CBD stone. Huh? That's what happens in this case. At the junction. It's like stone in the junction. Like, yeah. Where the cystic are joined to the common hepatita. So that's similar to having a virus. You will have a virus. Just a CBD stone will not give us distended gallbladder. Just a CBD stone, because we think that CBD stones coming from gallbladder. So if we can call a similar, so there is an element of chronic cholecystitis and gallbladder will not distend. That is the law. That is the law.
So when you have two stones, rise in the gallbladder, we can track it.
Because it causes mucosine. Because of mucosine. Because of the mucosine it distends. Not because of the intrabiliary pressure it distends. Distends because of the mucosine. Okay. So how will you investigate this patient? Start. The patient, 41-year-old patient, coming with obstructive jaundice for 1 month duration with significant loss of weight and loss of appetite. How will you investigate this patient? So how will you manage this patient?
After management, I would just like to confirm the diagnosis. Information. I would like to do the biological and the imaging investigations. And as per scientific investigations, I would like to do the full blood count.
No, you said you want to confirm the diagnosis. How will you confirm your obstructive jaundice?
With the biological investigations, I do a liver profile. To look for total bilirubin
And
and the direct bilirubin pressure.
when do you call it direct hyperbilirubinemia? When do you call it direct hyperbilirubinemia? More than 20% of, when the direct bilirubin is more than 20% of the water, call it direct hyperbilirubinemia. Okay. Then what are the other parameters that you want to look for? Liver profile. And gamma GT levels. AST-ALT may be deranged because of liver dysfunction due to biliary obstruction. Liver dysfunction due to biliary obstruction. So you want to look at that also, but your main aim is to look at the T-bill, D-bill, ALP and gamma GT, and AST-ALT of course because of the dysfunction. Okay. So that is to confirm your obstructive jaundice. Then to confirm the diagnosis, you need to go for imaging. Imaging. What will you first investigate that you do? Okay, you can do ultrasound scan of abdomen. What are the things that you will expect? The duct dilatation. Duct dilatation. You want to see whether the intrahepatic and or the extrahepatic ducts are dilated. If scan says CBD is distended down to the ampulla, where is the pathology? It is in the ampulla. Ultrasound says. If ultrasound says intrahepatic ducts are dilated but extrahepatic ducts are not dilated, Where is the pathology? It's at the high-level level. Then you narrow down your differences to either high-level CA or portable spleen factor with another primary. Isn't it? Right? So you are narrowing down. You get an ultrasound scan done to see the duct dilatation and which ducts are dilated. When the intravenous ducts are dilated, what does that indicate? Long-standing compression, long-standing obstruction, because it has to dilate against the river parenchyma, whereas extravenous ducts are free to dilate into the peritoneal cavity. There is no barrier around. Whereas intravenous ducts, it has to dilate against the parenchyma. So if the intravenous ducts are also dilated, so this has to be a long-standing obstruction, like 1 month. No, not it doesn't dilate over one day, 2 days. It takes time, right? So that's what it means. If the intravenous ducts are dilated without any obstructive jaundice, what is that condition? Caroli's disease. Is there a patient in the ward? Yeah, there's a patient in the male ward. Diagnosed patient Caroli's disease. Where intravenous ducts are dilated, but usually they don't have jaundice because there's no obstruction. It is the pathology. Intravenous ducts are dilated. Caroli's disease. It's a rare condition. Again, don't think it's common. It's rare. Very rare. Very rare. So go and see that patient's imaging. Patient will be discharged tomorrow. Other get well. So that's why you get an ultrasound scan done. What else? What is the next line of investigations? Why MRC? Why not CT first? What does MRCP give? I mean the details that you can gain from MRCP which cannot be gained from a CT. Yeah, ductal pathology. If you are suspecting something ductal, the investigation choice is MRCP. I agree, but generally we go for CT first. CTs first, because MRCP will not show extraductal pathology. Even if it's a malignancy, how far it has spread can MRCP pain. Even if it's a cholangiocarcinoma, how far it spread can pain. Unless we combine MRCP with MRI, MRCP per se will only give ductal pathology. Magnetic resonance, cholangiopancreatography, it just visualize the ductal problems. But if you combine MRCP with CT, yes. So we generally, because we don't have access to MRCP freely, we go for contrast enhanced CT scan. You have to say it, contrast enhanced CT scan. Because here, now as she said, first aim is to confirm your diagnosis. If you come across a malignancy, what is the next step?
Staging.
Correct. Yeah. Okay. एक answer is definite. हाँ ये कलर है इसी तरह. FFP runner बस INR है बैठी है. मोबाइल कलर इसी तरह है. Anesthesia पेन नहीं है. Lagi ni apa? Itu tak boleh balapan. Right. Those are not answers that can be given at the exam. Malagi. So we do a CT first, contrast enhanced CT scan, because second step is diagnose as well as staging to see whether this patient is resectable, the tumor is resectable. So resectability depends on the vascular invasion, local invasion and everything. To see the vascular invasion, you have to do a contrast enhanced CT. Contrast enhanced CT scan. At the exam, give complete answers. You can, I will do CT. Where? Brain? No, abdomen. Will you give contrast? Yes. So another candidate can answer, so I will do a contrast enhanced CT scan on the abdomen, but I will make sure patient has no allergies and bronchial asthma, and if the patient has bronchial asthma and allergy, prednisolone is given prior to the procedure. And I will also make sure creatinine is done and corrected if there is a problem. So examiner has no questions to ask, he can move on to the next question. Right? Because in a CT request form, there are two things that you have mentioned: bronchial asthma, allergies. If that is not documented, you will not be given the date. Right? You will not be given the date. If there is any allergy, at least we can. එතෙන්ට ගියාම අහනවා අපි මොනවද කිව්වොත් එතෙන්ට ගියාම අහනවා. patient කිව්වොත් ආයි මට මේ බලමාළු කෑනම නිකන් පළුවක් දැම්ම කිව්වොත් ඇති ආයි හරවල යනවා. කහන්න ඕනෙත් නැහැ. Because they are not willing to take that risk. Anaphylaxis. Right? So if there is any allergy, how do you prepare the patient for contrast CT?
Prednisolone.
Prednisolone how much? Huh? How many of you have had patients admitted for CT? Whose patient is, there's a male patient here with a neck goiter. Whose patient is that one? May I think goiter එකක් එක්ක තියෙන patient කෙනෙක් CT එකට admit කරා? මේ පැත්තේ මේල් කියන පිරිමි 100 කෙනෙක් ඉන්නවා. goiter කියන්නේ මේවා ගල ගණ්ඩේ තියෙන 100 කෙනෙක් ඉන්නවා. කාගේද අයිතිකාරය? No. There's a patient with a goiter. ගත්තේ නැහැ. patient admitted for CT කියන එක ගත්තේ නැහැ. Yours? Oh, නෑ ඊයේ නම් admit වුණේ. මොකද patient creatinine හොඳ නැහැ. patient is given NAC. No, patient is goiter. කාට අයිතිකාරයක් නැහැ. පස්සේ මම හොයලා අයිතිකාරයක් කියන්නවා. බලමු කාට ටිකට් එක ඇදෙන්නේ කියලා. කවුද වාසනාවන්ත කියලා බලමු ක්ලාස් එකේ කරලා. So, if patient has allergies, bronchial asthma, patient will be given prednisolone 30 milligram 12 hours prior and 2 hours prior to the procedure. 12 hours prior and 2 hours. ඔය ඔක්කොම රික්වෙස්ට් ෆෝම් එකේ දීලා තියෙනවා. ප්‍රොෆිනෙට් එකේ අස්කම් අරගෙන ඉන්න කියන්නේ ඒක තමයි. මේක ඉන්නකොට there are lot of things that you see, lot of things that you hear, you can use that for the exam. Don't think ඔක්කොම උගන්වලා පාඩම් කරලා විභාගයට යන්න පුළුවන් කියලා. You can't. You can't. It's not possible. And if the patient has renal impairment, we get a nephro opinion generally. And to prevent contrast-induced nephropathy, the key management is hydration. Because in a patient with renal impairment, if the patient goes into dehydration on top of contrast, patient will definitely go for contrast nephropathy. Therefore, the cornerstone of management for contrast nephropathy is hydration. Proper hydration prior to the procedure and post-procedure. There are a lot of trials done on giving certain drugs, but to date none of them have proven benefits. None of them have proven benefits, but still we do give NAC. What is NAC? N-acetylcysteine, oral NAC. We give oral NAC. N-acetylcysteine, although guideline says it has no proven benefit, we still give it oral NAC prior to the procedure and post-procedure also. ලෙඩාගේ අයිතිකාරය ලෙඩා ගලවනවා මේ ඔක්කොම ලෙඩාගේ ඉඳලා අප අමතක වෙන්නේ කවදාද මං කියපු දේ අනිවාර්යෙන් අමතක කරනවා. මොකද මම ඊ කියපු දේ වලින් අදහුවොත් ගොඩක් අය මතක නැහැ. මොකද මම දන්නවා මෙතන ඉන්න අයගේ 50%ක්වත් මම එදා උගන්වනකොට කියලා කියවලා නැති අය. You all have to study every day. Okay, every day. ගෙදර මිනිස්සුන්ට තේරෙන්න ඕනේ අපේ ළමයා දැන් ෆයිනල් එකේ ඉන්නේ ඉස්සරහට වඩා පොත් කියවනවා. Hello. Oh. නැත්නම් ඒ මිනිස්සුත් බලන්නේ අප ෆයිනල් එකේ කියලා වෙනසක් නැහැ ඉස්සර වගේම ඇවිල්ලා නිදා ගන්නවා. Just farting around. There's no change. Nada. Lagi mau ni? Ya.
Bongke langsung kita mengatakan. Tiga petik. Tiga petik tadi.
Kena apa ya? Kalau gila tadi mau apa? Kena apa? Okay. පාඩම් කරන්න ඕනේ හැමදාම. ඔතවදන්න ඔගේ ලියා ගන්නවා ගිහිල්ලා පාඩම් විසික් කරනවා. ඔයාලට වෙනසක් දැනනවද මේ ෆයිනල් එකට ආවයි කියලා ප්‍රොෆිට් එකට ආවයි කියලා දැනනවද මොනවා හරි? ඈ? එංගට දැනනවද කිසිම දෙයක්? මොනවා වගේ දේවල් දැනෙන්නේ? වැඩ වැඩි දැන් මහන්සි මම ගෙදර ගියාම මහන්සියක් දැන්නවද ඔයාලා? මොනවා කරලාද දන්නේ? හන්ද පුතාට මහන්සියද ගෙදර ගියාම? ඔයාට මහන්සි? ඔයාට ගෙදර ගියාම මහන්සි? So that's how you answer. I will do a contrast and CT scan after excluding blah blah blah. Now, for the question that I asked initially, how will you manage this patient? You can also start your answer by saying like this: Sir, this 41-year-old patient having jaundice plus long-standing loss of appetite and loss of weight. This patient looks dehydrated, so I will first resuscitate this patient. I will start the patient I will resuscitate this patient with regards to his hydration, hemoglobin and nutrition. At the same time, I will do necessary investigations to come to a diagnosis and also stage if there is any malignancy. You make opening statement for your discussion saying the overall picture of the patient. Obviously, 41-year-old jaundice for 1 month, severe loss of weight, and the patient looks dehydrated. Catechectomy. So, මොකද ගන්න ගිය ගාම බ්ලඩ් ටික අදලා ගන්නවා liver profile ඔක්කොම මගුල තියෙන බ්ලඩ් ටිකත් අදලා ගන්නවා. You have to take, what I'm saying is you have to tell that I would like to optimize this patient with regards to hemoglobin, nutrition and hydration, which cannot be done overnight, but you are concerned about it. And I will do my investigations to confirm the diagnosis, and if there is evidence of malignancy, to stage and proceed accordingly. To confirm the diagnosis, first I will do a liver profile and look in these. And then I will do a preliminary investigation ultrasound scan. These are the expected findings. Then I will do a contrast enhanced CT scan of the abdomen. And then, if there is any malignancy, stage the disease. Once you come across the diagnosis of malignancy, you generally do something else. We discuss that in a multidisciplinary team. Every Thursday at 10:30 we have MDT. ඔයාගේ patient MDT discuss කරනවා කියලා දන්නා නම් come ඒක දොර වහලා නැහැ. එන්න පුළුවන්. If you're lucky enough, you get free food also. එහෙම කියලා මුළු group එකකට අරන් ඉපැද්දේ. ඒක ඉඩ නැහැ. ඕන විතරක් එන්න පුළුවන්. හරි? We will discuss that in MDT, multidisciplinary team. Our MDT has consultant surgeon, radiologist and oncologist only. But generally, you non patient proper MDT. Consultant surgeon, radiologist, oncologist, physician, problem anesthetist, pathologist, and social care worker. Everyone has to come. We don't have that kind of MDTs. We have minimum facilities, so we have oncologist, surgeon, and radiologist. But if it is necessary, we get down other patients, other parties. So we discussed that in MDT. So that is the management plan. Okay. Are you clear about your blood investigation and imaging? Yeah. So you do a CT. If you are suspecting any biliary tract malignancy like cholangiocarcinoma, then there's a place for MRCP. But if your CT shows obvious pancreatic head CA, then there is no place for MRCP. You don't have to do MRCP because you know the diagnosis. But if CT says this is possibly a cholangiocarcinoma, to get the exact level of the cholangiocarcinoma, you can do MRCP. Then that is the place for MRCP. That's why we don't do MRCP prior to CT. Sometimes we can skip it. Plus we don't have access. Right? So MRCP is second line investigation. So third line. Yeah, we discussed about tube marker. So investigations can be of 4 categories basically. First, to confirm diagnosis. Second is to stage and assess the resectability. Third category is your pre-op investigations or to optimize the patient. Fourth category is your special investigations. Those are the 4 categories of investigations. To confirm the diagnosis, biochemically liver profile, and then you do your imaging. We have already discussed. Staging, you discuss the imaging, you do your imaging and discuss at MDT. And then decide whether you are going to do curative management or your palliative management. We discuss that later. Then your pre-op investigations or optimization. That there comes your all full blood count, INR, renal functions, electrolytes, you name it, everything. If necessary, 2D echo, ECG, lung function test. If you think they are necessary for optimization, you can do all investigations under that. If it is relevant. You know, for the special investigation, you have tumor markers. You can do your baseline tumor marker levels. Baseline tumor marker levels. So pancreatic biliary tumor marker is CA19-9, CA19-9. CA19-9. CA19, that is a tumor marker. That also gives you idea. You know, if it comes as 20,000, you know that this has to be a metastatic disease. You know, you have to extensively investigate for and look for metastasis even if it's very high. Otherwise, it will be just a baseline investigation only needed for further follow-up. And tumor markers will never confirm the diagnosis. Just to give idea about it helps for the diagnosis. Plus, it is needed for follow-up. It doesn't confirm the diagnosis. Okay, so these are the 4 categories of investigations. Any questions up to now? Yes. As in secondary meds. The secondary is from biliary tract malignancy.
No, if the primary is somewhere else, if there are meds in the liver, can we use like
No. Now, for an example, if it's a colorectal metastasis, tumor marker is CEA.
So is it the primary, tumor marker specific to the primary?
Yeah, definitely. If it's biliary tract, pancreatic CA19-9. I wouldn't say it is specific, 100% specific, but there's some specificity. Whereas for the colon, CEA, and let's say for the thyroid, thyroglobulin. For parathyroids, calcitonin. Not parathyroids, the medullary calcium thyroid, calcitonin. Okay, there are two markers. For the breast, there's another one we don't use much, CA15-3. We don't use it much. So it is specific to the primary, not 100%, but there's some specificity. So if it's a malignancy, CEA කරන්නේ colorectal එකකින් මෙත් ආවත් ඉතින් pancreas එකේ metastatic level CA19 will be high.
Like cancer. දැන් අපි pancreas එකෙන් liver එකට metastatic වුණාම liver එකට අදාළ tumor එකක් තියෙනවා.
liver එකට අදාළ tumor එකක් කියලා නැහැ. primary එකට අදාළ tumor එකක් නැහැ. liver එකට අදාළ tumor එකක් කියලා නැහැ. And this is primary liver tumor, hepatoma and alpha-beta protein. Primary liver tumor and alpha-beta protein. Yes. Yeah. Exactly. That's why I said it's needed for further follow-up. You need it as a baseline investigations. So if it's going up, then you have to, especially colorectal CA, we need to have a baseline CA level. Because it's going up, we have to investigate for a metastasis. If CT is negative, we have to go for a PET scan. Right? We'll discuss that with ERB. Okay. So if it's a cancer, we discuss that at NEET and mainly decide whether you are going to go curative option or you are going to palliate the patient. So those are the two decisions that you take. So tumors can be either resectable or unresectable. Right? Unresectable. Late diagnosis. Unresectable. So unresectable patient goes to which category? Palliation. And resectable also you have to think of fit patient, unfit patient. Resectable but patient not fit for surgery, patient goes to palliation. So these are the decisions that we take. We discuss everything, patient's profile and everything. Radiologists might say, okay, this is a resectable tumor, but we are saying this patient is ASA3, having ejection fraction of 35%. Will you do because? No, we are going to palliate the patient. Just because it is resectable, we don't, ledamalat badasindai kiyala kapalayin karanna bෑ. Coffin එකේ pancreatic tumor එක නැහැ. That's something. Sure, 100% sure. Patient goes home in coffin with no pancreatic tumor. It's in the pathology lab. So resectable, unfit, and unresectable patient goes to palliative care. Okay. So resectable, fit patient, we go for curative treatment. So curative treatment depends on this. I know the method in harder. ටිකක් advanced. ගොඩක් වෙලාවට long case එක discussion එක මෙතනින් එහාට යන්නේ නැහැ. මෙතනින් එහාට යනවා නම් there are only two possibilities. Either you have performed extremely well and exam is running out of questions, or you have not answered any, exam is trying to at least ask high-five questions and see whether you know that, at least you know that high-five answers. So when you come out of the panel, you decide in which category that you fall into. If you ask high-five questions, there are two possibilities. තමන්ට තේරෙන්නේ එළියට යනකොට තමන් මොන කැටගරි එකේ ඉන්නේ කියලා. ඒ තේරෙන්නේ නැත්නම් කෙලින්ම සයිකියාට්‍රික් එක්සෑම් එක අතහැරලා ඉන්නවා. ඒක poor insight කියන එක. So biliary tract malignancies, gallbladder, If it's a malignancy here, periamphallar CA, distal phalangeal CA, and pancreatic head CA. Resectable, curative option. What is the curative option? Huh? What is the surgery? Whippers is not the best term. Whipper is because it was described by a person called Alan O. Whipper. You call it Whipper, but the ideal surgery is pancreaticoduodenectomy. Pancreaticoduodenectomy. Well, I'm going to go to pancreaticoduodenectomy. What do you mean? That's a month. Huh? Because pancreaticoduodenectomy. Oh, pan tiga. मैं तो बोले pan tiga क्या? नहीं. Kawan, enak ICU kan? Ratu ekai, nil ekai, kalu ekai, turun. Dia mana? Harna. Okay, so we first pancreaticoduodenectomy. So pancreaticoduodenectomy क्या क्या है? So malignancy is here, somewhere here. Malignancy is somewhere here. We can't just locally excise this part. So we have to do pancreaticoduodenectomy. You cut from the antrum, you cut from the bile duct, cut from jejunum, and cut from the neck of the pancreas, and we remove this part on block. And then we reconstruct. So there are how many anastomosis? Gastrojejunectomy. First we do the pancreaticojejunostomy, that is the deepest most anastomosis. Pancreaticojejunostomy, choledochojejunostomy, gastrojejunectomy. Okay, these are the three anastomosis. May or may not have jejunostomy. Samara network karan pulang. So that is those are the three. This is called triple bypass or pancreaticoduodenectomy. Or because is not the best term to use because procedure because it is described by a person called Whipper. So there are two types pancreaticoduodenectomy. Some people can do pyloric preserving pancreaticodenectomy. Pylorus can be preserved. That is PPPD, pylorus preserving pancreaticodenectomy. Nobody will ask what are the steps in pancreaticodenectomy from you all. Not even part 2 in surgery. So it's a major complex procedure, complex major surgery. Patient has to be really fit for surgery. Age is not a barrier. If the patient is fit. Right. So that is a curative option. If it's a proximal malignancy, treatment is so totally different. I don't think you need to know that much. The patient may or may need a hepatectomy, depending on the extent of the disease. Okay? Right. So that is curative. If you are interested or during board rounds, we will discuss more about these surgeries because you will come across a lot of patients. So we will discuss. There's another patient getting admitted on Sunday. Female ward for Whippers. And I think tomorrow after 12 o'clock it's Sunday. You all don't have to come. You know that, no? This Sunday is off. දුකයි නම් එන්න. ඒක කිව්වම තමයි දුකින් එන්නේ. දුකයි නම් එන්න පුළුවන්. But remember, Monday morning, if you don't have history of one of the patients in your ward, you can't say Sunday was a holiday. Either if you are at a risk of getting a patient, let's say it's your turn, it's closer, either you have to come in Sunday night and take the history, or Monday early morning and take the history. By 8 o'clock, be ready with the histories. Okay? You can't say, ඊයේ නිවාඩුනේ ඉතින් ආවේ නැහැ කියලා. You can't say that. එහෙම වුණා ඊළඟ සතිය ඉරදා නිවාඩු නැති වෙයි. Profit. It's different. ගෙදර මිනිස්සුන්ට මම වෙනසක් දැනගන්න බෑ හරියට නැත්නම්. ගෙදර කවුරුයි කිව්ව ගෙදර ගියාට තේරෙනවද ඔයාලා දුකින් ඉන්නේ අමාරුයි ඉන්නේ කියලා තේරෙනවද ගෙදර අය? තේරෙනවා. කවුද ගෙදර ඉඳන් ඉන්නේ මෙතන? How many of you are coming from home? 1, 2, 3, 4, 5, 6. අනිත් hostel boarding place. මම උදේ weekend එකේ ගිහලා කාලා ගෙදරින් කාලා අම්මලා දෙනවා කාලා. සඳයිනෝ සතුටුයි. Right. So then we come to palliation. So what are the things to palliate? Krishna, what are the things to palliate? What are the things to palliate in a patient in a patient of obstructive jaundice? It's a separate huge topic, but we try to summarize it. Palliative care is a separate medicine, separate specialty. What are the things to palliate?
Optimize the quality of life of the patient.
Okay, you got to palliate certain non-surgical aspects. Think about the surgical problems. What are things to palliate in your patient? One is obstructive. You have to relieve the obstructive jaundice. Because the moment you relieve obstructive jaundice, their nutrition gets better, they can eat. Because malignancy also causes certain degree of loss and obstructive jaundice also contribute. So we have to palliate the jaundice. That's one thing. And it's a malignancy around the gastric outlet. So can they have gastric outlet obstruction? Yes. So you have to palliate vomiting. That is also common. You have to palliate pain. That is also right. You have to palliate what? Psychological aspect. Right? Or social, spiritual, whatever you call it. Thereafter a comment comes. The comment comes after that. Psychosocial, spiritual, and blah 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 is your comment. Okay? By the way, who has decision comment? Who has decision comment? Who has decision comment? You are exceptional. Yeah? Who? No, it's good. I'm really how can I say? I'm really proud of you. I don't know how do you do it. Amazing. Did you go for lectures? අපේ බැච්චේ lectures ගන්න එන්නේ නැහැ අවුරුදු. මම හිතන්නේ දැන් ඉන්ටරෙස්ටිං ඇද නේ ඉස්සරට වඩා. එහෙමද? දැන් අපි කරපු වැඩවල ප්‍රතිඵල ඇති. අපි lectures ගියා නම් ඒකයි අද ඩිස්ටින්ක්ෂන් නැති වෙනා මේ. අපි නොගිය පිටුනා රෙජිස්ටර් මාක් කරන්න පටන් ගන්න ඔය ළමයි ගිහලා ඉගෙනගෙන තියෙනවා. I'm proud of myself also. So obstructive jaundice, how do you palliate it? You have to relieve the obstruction. By means of stenting. Right? So you have to put a stent. How do you put it? ERCP and stenting. There are two types of stent, metal and plastic. Plastic stents and metal stents. You will see all these things, don't worry. Metal and plastic. You decide on the life expectancy. If you think that this patient is not going to survive for another 1 month, you might as well put a 8,000 rupee plastic stent. If you think this patient has a better quality of life, this patient will survive for a longer duration. Let's say resectable tube but unfit patient. Patient is not going to die of the malignancy because it is still in resectable stage. You will put a metal stent, which costs about 150,000. Right? All are given by the government sector. So you can put a metal stent. So that is depending on the life expectancy. So vomiting in patient with malignancy. What are the possibilities? What is the thing that you want to exclude? If the patient with obstructive jaundice, if patient start vomiting, what is the thing that you want to exclude? Gastric outlet obstruction. And what kind of vomiting is it? Immediately after meals, not immediately, just maybe half an hour, 1 hour after meals. Projectile vomiting, not a simple vomiting, projectile vomiting. So then you suspect gastric outlet obstruction. What is the sign that you elicit? Succussion splash. How do you elicit? Have you all heard it? No? අද බෝඩිමේ ඉන්න යාළුවාට හොඳට වතුර බොන්න දෙන්න. හොඳට වතුර බෝතලයක් බොන්න වතුර. බෝතලයක් බොන්න දීලා ස්ටෙප් එක යාළුවා එන්නේ හාන්සි කරලා ස්ටෙප් එක කයින් දෙලා බඩුවින් දීලා යාළුවා මෙච්චර හොලවන්න එකපාරට. You can hear succussion splash. හොඳට වතුර බීවම ඕන කෙනෙක් ගහනවා. But යාළුවාගේ පැය 4කට පස්සෙත් ඒක ගහනොත් ඒ කියන්නේ යාළුවාට gastric outlet obstruction කියනවා. යා වතුර ටික empty වෙන්න පටන් ගන්නවා. If you have not heard it, you can do that. So succussion splash. මෙහෙම හොඳට නැතිනම් කන තියලා හුවත් එහෙම නැත්නම් ස්ටෙප් එක දිහා එළවුවාම බැලුම් බෝලේට වතුර පොල් දාලා හොලවනවා වගේ. ඔයාලා කලවල නම් වතුර හැදෙන සද්ද අහලා නැති වෙන්නේ. ප්‍රශ්නේ. නැත්නම් කලේ හදන්නත් එහෙම එහෙම. Succussion splash. So that is the thing that you want to exclude in a patient with this malignancy, whether it's a gastric outlet obstruction. If it is so, you have to palliate that. If it is vomiting, exclude gastric outlet obstruction, G-double-O. Don't pronounce it, say G-double-O. Kiyane ka harna hai. Kiyane ka harna hai. G-double-O kina kiwa happa ho kiyane. So exclude that. If you think if your diagnosis is G-double-O, you can either palliate by using a stent, duodenal stent, or you can do a palliative surgery. How do you palliate the surgery? You do a gastrojejunostomy. You palliative surgery. You don't need to know that much. So that. What are the other causes for vomiting in a patient malignancy? Huh? Either if they are on chemotherapy or painkillers. They may be on morphine. Most of the malignant patients are having chronic pain. They are on morphine, and morphine is very emetogenic. Your pharmacology. So then that is the other drug-induced vomiting. So if so, you can give antiemetics. What is good for drug-induced vomiting? Ondansetron. What is the receptor that it blocks? 5-HT3. Okay. So that is for vomiting. That is another thing to palliate. Pain. Again, important concept, important to palliate. Right? So, have you heard something called analgesic ladder? WHO analgesic ladder. Is it acute pain or chronic pain? Chronic pain. So you step up the ladder, step down the ladder. You step up the ladder. You step up the ladder. So you start with simple ones. If they are not resolving, you step up the ladder. But although this ladder concept is there, now the current trend is to use multimodal analgesia. Rather than giving one drug to its maximum dose, you combine 2-3 drugs together to relieve pain. What is the advantage of combining 2-3 drugs together? It reduces side effects because you don't have to go for maximum dose of one drug, and you get synergistic effect. Sometimes some drugs have synergistic effect. Now, NSAID have a morphine sparing effect. Likewise, you combine. So, depending on their side effects profile, you can combine multimodal analgesia. So, that is the current concept, but you need to know about the ladder as well. We'll discuss about post-op pain separately. It's a separate minor topic. So, I say this, we discuss here, you have to remind us also. We will not come, I will forget to teach. Those are myoclonic jokes. Right. So you have to remind us, okay? So that is palliation of pain. Another thing we have is nutrition. They are nutritionally very much depleted. Loss of weight, appetite for months. So how do you palliate this part? Krishani, what is tumor cachexia? What is tumor cachexia? I'm asking from her because she's the other mage. Target එක මෙයා. නැත්නම් එයාගේ කොලේ මාක් කරන්න බෑ. කොලේ තියෙන හොම ඩිස්කෂන් එක කරේ එකම තියෙන කොලේ. What is tumor cachexia? Loss of what weight? Anyone? Loss of lean body mass. Loss of lean body mass in a patient with malignancy. How do you explain this? Have you ever read this part in your Robbins? Chemopathology was done by අපේ කෙනා මේ පැත්ත මෙහෙම පෙරනවා මේ පැත්ත නොට මෙතන දාන ටියුමර් කැචෙක්සියා තිබ්බේ. අතන ඔයාලා කොහොමද තිබ්බද කියලා. Yeah, the fact that tumor cachexia occur in a non-GI malignancy, that explain this is not the GI problem causing loss of appetite. Central control of appetite is inhibited by the tumor factors. Isn't it? The central control of appetite is inhibited by the tumor factors. That explains why tumor cachexia occur in non-GI malignancies also. If it is due to GI problem, only GI malignancy should get tumor cachexia. If not, it is not. Even sarcomas get tumor cachexia. Lungs get tumor cachexia. Why? Because of tumor factors, central control of appetite is inhibited. So interleukins and tumor necrosis factor alpha will inhibit your central control of appetite. That's why they can't eat. Causes low lean body mass. So they are having poor history. So how do you optimize their nutrition? These are palliative patients. How do you optimize their nutrition? What are the methods of feeding? Most of nutrition is a separate topic. Apart from 11 long cases, there are so many other topics like this: nutrition, cost of pain, cost of fluid, DVT, so many. So we will have to work really hard to cover all these. What are the methods of feeding? Enteral and parenteral. What do you think? Which one is good? Obviously enteral. Why? More physiological. Okay. Sound comment? Again. So it's more physiological. And patient also feels good. කොච්චර වැඩක් නැහැ බටයක් දාලා වෙන්න දුන්නා patient කන්න පුළුවන් නම් තමයි හොඳ. So the enteral feeding has lot of routes. One is oral, the other one is NG, the other one is NJ, so jejunal, the other one is feeding jejunostomy or feeding gastrostomy. For a palliative patient, we don't consider parenteral. Just to prolong life, there's no point of giving parenteral nutrition because there are so many complications of parenteral nutrition. So patient will die of complication of parenteral nutrition. Therefore, you will consider enteral, but if patient cannot take orally, you have other methods of feeding like NJ feeding, NG feeding, or gastrostomy or jejunostomy feeding. Right? So that's how you optimize the nutrition. Psychological support, of course, you can get the help of psychologist or a social care worker. So support them psychologically, and you have to not only the patient, the family also you have to give the psychological support. Young patient having malignancy, breadwinner of the family is affected, so you have to refer them to social care workers. You have to support them. I'm not good at it, but you do something like that. Bereavement. You pat on the shoulder and say, he's going to die. So that is not the way you should support it, but in a better way. So that's how you should support it. So these are the palliative methods. Okay. So one more thing about the drainage. Now, do you all understand now? Curative, palliative. Curative I have discussed. and palliative, these two categories, these are things to palliate. Okay? You can restent it. You can remove it and restent. If you put a metal stent, sometimes we can't remove, especially if it's uncovered stent. Because block වෙන හේතුව තමයි uncovered stent එකේ දැල් අතරින් tube එක grow වෙලා block වෙනවා. ඒතකොට ගලවන්න බෑ stent එක. ඒ stent එක අතරින් ප්ලාස්ටික් එක වුණා. ඒවත් දල ඉතුරු සමාස දෙකේ ඒවත් බලන්න පුළුවන් බලන්න. Block the stent to them. We do about 14 ERCPs on Wednesdays. So we see a lot of patients. Right. Right. About drainage, biliary drainage. This is palliative drainage. Some patients needs drainage prior to surgery also. Those who are awaiting curative surgery, we drain them. That's called preoperative drainage. We consider preoperative drainage, pre-op drainage, if your surgery is going to take more than 2 weeks. Let's say we don't have a list, or patient is not fit, albumin has to be corrected, because we don't do a major surgery like this in a patient with low albumin. Now these patients can have low albumin. Why? Because they are cachectic, they have not eaten anything for last 2 months, so they are low. For low albumin, we don't do this surgery because hyperalbuminemia cause poor tissue healing and cause anastomotic leakage. So like if we want to optimize the patient, so it takes time. Sometimes we don't have tier list available, so it takes time. So we train them prior to surgery. That is preoperative. One thing, optimization take more than 2 weeks. Intractable pruritus is another indication, especially if we can't do the surgery within next 2 weeks. One of the main problem is intractable pruritus. They can't sleep. They're sleepless because they have so much of itching. So the moment we put a stent, the itching disappears. Right? So that's another indication, intractable itching. And thirdly, if they have cholangitis, is it a likely cause? Is it a likely pathology? Cholangitis? I told you no. But if in case if they have cholangitis, can we do a major surgery in a patient with cholangitis? No. So we have to drain it, optimize cholangitis, do it later. So in a patient with optimization takes more than 2 weeks. In a patient with intractable pruritus, in a patient with cholangitis, we have to drain preoperatively. Preoperatively. Right? Then how do you drain it? Is the next question. We have 2 methods of draining. One is retrograde. The other one is antegrade. Antegrade. Retrograde means your ERCP. Retrograde cholangiography. You go from the bowel and going from the other side. Like for an example, if it's a distal pathology like this, one of the 3, periampillary, distal cholangio or pancreatic head carcinoma, you can put a ERCP and a stent prior to surgery. But if it's a hilar cholangio, like in Ajit and Veera Singh, 2 patients in the ward currently, one is Ajit, the other one is Veera Singh. Whose patient is that? Veera Singh. So that patient, what does he have? What do you call those drains? EBD, yeah, external biliary drainage, right? So now if it's a very high up malignancy, to drain the system, you can put a EBD, external biliary drainage. But is it a method of palliation? Can you let this patient be on this stent? Guaranteed, right? In the next 6 months, both are going to die. So within even masa so we have put a just temporary method. EBD is a temporary method. We have to put an antegrade stent. He is awaiting antegrade stenting. We don't have facilities at the moment. So that is external biliary drainage. There's a lot of things to learn about it. We discuss later. So that is but that is not a method of palliation. We can internalize it later and integrate later. But if it's a pre-operative patient, now let's say we are going to operate on Veerasinghe, but if you want to drain the patient prior to procedure because of one of those reasons, indications that I told, cholangitis, intractable pruritus, or optimization take more than 2 weeks, if you want to drain a patient with a high proximal obstruction, the method of drainage is EBD. Method that are drain karna until surgery. Because their obstruction is proximal. You don't try to push a stent from below up. So those are the indication of preoperative drainage, and the methods of preoperative drainage are antegrated retrograde. Okay. Any questions? Then tentorium එකෙන් පල්ලහැට cerebellum එක කියලා දාලා තියෙන්නේ. Chicken mo biology. Tutu mulai darah kan nama tu. So tomorrow dysphagia tube. ऐसे का ऐसे पता नहीं ना? Have you all started doing MCQs? Huh? Yes. මේ group එක හොඳයි. කවුරුත් ඇවිල්ලා MCQ එක ඇහුවේ නැත්නම් ඒ කියන්නේ ඔක්කොම දාන්න උත්තර දෙන්න. Exception. Are you have questions? මේක ලියන්න ගන්නේ. 55 මේ ප්‍රථම ප්‍රොබිලි ඩිස්ක්‍රිප්ෂන් solid 1 month duration accompanied by weight loss, smoke and cigarettes daily 25 years. Okay. මේක ලියන්න. ඒක හැමෝටම කිව්වද? ඒක දාන්න හැමෝටම. දැන් ලියාගෙන ඉන්න. Questions? Evan, pop Evan. Those who are shy to ask questions in the mass class, you can ask individually also. Some people are very shy. Like you guys are still can still come and ask, no problem. But then they have what advantage, others are also benefited. You know, advantage. Which question? No. එහෙම කරන්න නෙමෙයි. මම කියන්නේ questions වලට උත්තර හිතාගන්න බැරි questions තියෙනවා. That I don't know. You just have to say goes to Google search the same question. මේක type කරලා Google search කරලා බලන්න. Any questions මොකක්ද උත්තර දෙන්න බැරි? So then what MCQ කරන්න ගත්ත නැති පටන් ගන්න යනවා ඉන්නවනේ පටන් ගන්න. මේ අපොයින්ට්මන්ට් එක ඉවර වෙනකොට සර්ජරි MCQ ඉවර වෙන්න ඕනේ. වයිවා ටොපික්ස් කවර් වෙන්න ඕනේ. අන්තිම හරියට ඔස්කියුලර් ක්ලාස් ති වෙන්න ඕනේ. පුළුවන් තරම් ෂෝට් කේස් කරලා දෙන්න ඕනේ. ලොන්ග් කේස් 11ම කවර් වෙලා තියෙනවා. Lot of things to do. ගෙදර ගිහලා ඉඳා ගන්න පොඩ්ඩ වෙලාවයි පුළුවන්. හරි. දවස ගානේ මෙහෙම වැඩ කරොත් finals කියන අමාරු එකක් නෙමෙයි. It is the easiest out of all the exams. දවස ගානේ වැඩ කරොත් daily basis වැඩ කරා. ඉඳලා weekend එකේ ෆන් එකක් දාලා ඉන්න පුළුවන් ප්‍රශ්නයක් නෑ. ගෙදරට දැනෙන වෙනසක් දෙන්න. මගේ දුව දැන් ෆයිනල් එකේ ඉස්සර වගේ නෙමෙයි. හරි මහන්සි වෙනවා කියලා තවත් අලා තම්බ දෙයි කන්න ගෙදර ගියාම. understand what I mean? So, you look very. Greek kata apa nama orang muda tu? Cause of obstructive jaundice fatty liver? No. Obviously not. There you go. 35-year-old woman came with intermittent fever for 1 year. She is unwell. She is having intermittent abdominal pain, distension and loss of weight. On examination, mass in LIF. Which of the following kind was this? Carcinoma of the rectum, chronic amoebic colitis, abdominal TB, typhoid ulcerative colitis. I don't know. I really don't know. Maybe abdominal TB. Because carcinoma of the rectum unlikely. They don't present with fever or anything. Ulcerative colitis is not the typical history. Typhoid is acute. So it is either chronic amoebic colitis or abdominal TB. Huh? Yeah. Obviously, hypertrophic ileocecal meningitis is the commonest. So I don't know the presentation of chronic amoebic colitis. Maybe you can read. No idea. And remember the other thing is all these MCQs, your actual MCQs are easier than this. Because මේව ළමයි එළියට ගේන්නේ. ගේනකොට හරි වචන ඒ වර්ඩින් ඒ විදිහට වෙන්නේ නැහැ. සමහර ඒවා පොඩ්ඩක් වර්ඩින් වෙනස් වුණාම ප්‍රශ්න සම්පූර්ණයෙන්ම අමාරු වෙනවා. So actual MCQs are easier than this. Okay? I don't know the answer. Any questions related to painless and painful obstructive jaundice? Fatty liver. Fatty liver is a risk factor for hepatoma. It's on the rise. More than alcoholic cirrhosis leading to hepatoma, non-alcoholic fatty liver disease causing hepatoma is on the rise now. More and more. Gallstones formation increase when excess accumulation of bile salts. Cholesterol stones are radioactive. Radiolucent means? Yeah, radiolucent. Generally, they are radiolucent. Are they radiopaque stones? Cholesterol? You cannot. Hello, sir. Okay. See, I have to take a cut here. දැන් ඉන්න කට්ටිය අන්තිමට ඉවරෙච්ච චොල තුන්දෙනාටයි. අන්තිමට ඉස්සරහ දෙන්න. ඔව්. මැසේජ් කියන්නේ. ඉතින් කන්ඩිෂන් එක නේ දෙපාර්තමේන්තුව දාගන්න. දෙපාර්තමේන්තුව දාගන්න. radiopaque किहुआम radiopaque किहुआम it gives the idea they are radiopaque. Are you tricky questions? What I would do is I will skip the question. You should learn how to skip pause. I have gone for paper marking for 2-3 batches. You all lose marks because of negative marks. Lot of marks because of negative marks. Good afternoon. I went for 18 and 19, no, 17 and 18 batches of paper marking. Any other question? Anyone else? Gallbladder palpable diabetic disease. No, gallstones are associated with diabetic disease. What do you call that triad? Sainz triad. Diabetic disease, hiatus hernia, gallstone disease are common associations. Sainz triad. S-A-N-S-A-J-I-N. Monodiabetic is क्या gallstones are associated with duodenal diabetes. CBD stones are associated with duodenal diverticulum. Agree? Because duodenal diverticulum, the drainage is not normal. The sphincter of body special mechanism is not normal. There is a sphincter of body dysfunction. Therefore, there is a possibility of primary CBD stone formation. Again, सामान्य we assume that gallstone CBD stones are coming from the gallbladder, but sometimes we come across large CBD stones. They are primary CBD stones. Causes for primary CBD stones are sphincter of body dysfunction, or if there is any stricture in the CBD above the stricture because of the stagnation, and polydeutal cyst. Again, stagnation causes biliary sludge, it acts as an nidus, and on top of that stone forms. So polydeutal cyst. Those are the causes for primary CBD stone formation. Sainz triad के लगे हैं colonic divertical disease, gallstone disease, and hiatus hernia. There are 3 common associations called Sainz triad. ඒ කියන්නේ ඒ තුනම එක්කෙනෙක්ගේ තියෙන පුළුවන් responsibility එකක් තියෙනවා. නැත්නම් ඉතින් ඒකට මේකක් නේ. What? Diabetic disease where? Ample, no. Diabetic disease in the block වෙන්නේ නැහැ සාමාන්‍යයෙන්. No, it doesn't happen. I'll show you what does it look like. When you do ERC, we see a lot of periample diverticulum.